Oh, hey, Chris.
Hey Chuck, how are you?
It's good. We're recording in the evening. It's kind of nice. I found some energy. I hope you did too.
I did. It's been a day. In my youngish attending years, I think I've kind of gotten the two-room thing down better than before. Block utilization ended exactly at 4:58 p.m., so you'd be proud. But I had this whole day planned out. I was in my mind. I was like, I gotta get home. I was gonna make dinner. I wanted to hang with the kids a little bit, and I get home and I'm locked out.
That
So it's
is,
just the worst feeling. I switched cars and I forgot to pull my house key, and then my wife is on consult, so she got called to the hospital to do a consult. So my father-in-law, who's almost always home, left to bring one of our kids to an activity. So I'm sitting there doing emails outside in not pleasant weather. It's really frustrating because I had this whole everything planned out to a cadence of like when I was going to get the oven preheated, the dinner prepped, everything in, and it was going to be all good by the time my kid got home from hockey practice, and then blown away.
did you order pizza?
Now we got it done.
How long were you stuck?
We got it done. We just pushed the timeline back a little bit. My wife was kind enough to come home before seeing the consult because she's already on her way to the hospital. Let me in the house, gave me a look, and then lovingly left me the key, and then went and saw the consult. I got dinner ready, and it's all okay. Just push back our recording time a little bit.
Yeah, my story is my family used to spend a fair amount of time up in New Hampshire with Talia's family at our lake house, and those it used to be many weeks, and now it's not. And they left yesterday, yeah, Monday morning early, and I'm joining them late tomorrow night after a crazy day in the OR. So I don't usually stack cases before I catch a flight, but I think I'll be okay.
The old Rick Wright adage. He's given me so many pearls of advice over the years. He hasn't given them directly to me, but he's kind of given when he was here at WashU, giving like junior faculty advice. And one of them was, there is nothing more stressful than operating before a flight.
True. It's true.
But yeah. So here we are, and excited. We've had some great engagement from folks recently. There is a really great review that I was hoping you'd let me read.
I would love to hear it. Thank you.
All right, so this is recently from Brit Mitch OTRL. 5 stars, of course. Always 5 stars, y'all. Thank you for all that you do. Chris and Chuck, not Chuck and Chris. Thank you. Brit,
Oh,
I want to thank you so much for creating this podcast, which has provided me the opportunity to listen and learn about the hand and upper extremity over the past year and a half while I study for my CHT. That's for those outside of the US, that is a certified hand therapy examination, has many hours of patient care contact related to hand and upper extremity, and a really rough test. Um, so Britt continues, I'm happy to announce that I have successfully passed my CHT exam on the first attempt. Listening to the upper hand helped me to understand the surgeon's perspective. I really enjoyed and appreciated the collaboration episodes and discussions with Macy. You helped me make my studying experience more interactive, and I have learned a great deal from you both. Thank you for answering my questions I had along the way while I studied for my exam. I plan to continue to listen and learn to the upper hand as I continue into my professional career as a CHT. Well, Britt, thank you for that, and congrats on passing your exam. It's wonderful.
absolutely. It's not an easy test, and I've known very impressive therapists take it more than once. And so, congrats. And I'm glad to hear you're going to keep listening because maybe you'll share some insights with us moving forward.
Yes, and we're gonna get do a little bit of a listener grab bag email episode today. So remember to send questions, comments, thoughts, suggestions for episodes to handpodcast@gmail.com. And maybe we'll get on this new thing, threads, that everybody's doing. By the time this drops, it'll probably have reached, half of the world. But yes, for now, send us an email because we're old.
I am on Threads, and the way it links into Instagram is really nice. I would say, and I kind of had been boycotting Twitter, as I think you know. Still not eager to go back on Twitter, but just comparing them, content on Twitter still is significantly better than Threads. But I'm hopeful. I'm hopeful.
It's just a different vibe, different. I think different generations. I've listened a lot of podcasts I listen to have had way too much coverage about the Threads thing, so I've been forced to learn a lot about Threads and about Twitter's recent issues. I'll say I have also been off Twitter for a while out of kind of pseudo protests as well. But I guess there's a reason to re-engage. But first, before we go further, let's thank our sponsor.
Absolutely. The Upper Hand is sponsored by practicelink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand. And special shouts to Ken Allman at PracticeLink. He was kind enough to host 12 of our WashU orthopedic residents at a recent soccer game in his amazing luxury box. So thank you for that. I know the residents really, really, really enjoyed it.
They loved it. They shared a great picture, which Ken appreciated. And yeah, it was very, very generous of him. And we as a department had an event. We haven't had a whatever you want to call it, an annual event, a holiday event, anything in quite some time because of COVID and just trying to find the right venue. And you were traveling, but Saturday night was really something special. Actually, at the soccer park, there's a huge venue, the Michelob Ultra Club. It was awesome. And really, Amanda did a great job, and the vibes were really good.
Yeah, I heard great things from everybody who had a chance to make it. Unfortunately, it fell on my son's birthday, so as you mentioned, could not make it myself. But look forward to doing it again, going at some point in the future. I hear the hand service took home some hardware.
The hand service took home some hardware. Yes, our division was the Press Ganey highest average score, which I think should come to no surprise to us at least. I think we do
Well,
well.
I'm glad we have people like you to bring up the score because again, it's an average. So, when in my clinic we keep tier tallies, so that is the number of patients that have cried during office encounters with me. So sometimes my scores probably aren't that good.
Your scores are good. Population matters to these things. Work comp probably doesn't help my scores. Dr. Calfee, it leads the way for us. He was edged out for the highest in the department, but still pretty impressive.
Yes, I believe was that Dr. Keener on the shoulder
It
service who
was.
also took
That's
home that trophy.
absolutely impressive work by Dr. Keener.
Yes. Well, speaking of impressive work, I wanted to get your thoughts on a case that has been emailed to us by a friend of the podcast. We have tremendous reach, Chuck. This is our second discussion we're going to have based on a case from Giannis in Athens. So, Giannis Lakanos, thank you for emailing this question and obviously for your questions in the past. So here's the case. And he said maybe suggest a subject for an episode. So the case is a 45-year-old right-hand dominant man who sustained a left small finger PIP dislocation 6 months ago in a basketball game. Was reduced, closed reduction in an outside institution, immobilized for a few weeks, and then sent to physiotherapy. And he comments that unfortunately they don't have any dedicated hand therapists in Greece. At least there aren't that many. And he came to Mr. Giannis's clinic with a subluxated, very stiff PIP joint, which is stuck in extension with no active or passive flexion. And there was no difference in the position of the MP when the MP joint was flexed or extended. And his DIP motion has 0 to 20 degrees actively and passively. No pain, and has managed to cope with his activities of daily living. Again, this is affecting his small finger on the left side. But the lack of flexion bothers him. For example, he cannot fit his hand in a boxing glove. Seems like quite the active guy. I hope to be like that when I myself am 45. Given his severe stiffness, what do you think the most appropriate course of action is? So, Chuck, what do you think? Maybe you could. Giannis did send us some X-rays. I don't want to be at risk for vertical pimping, but do you want to tell us what the X-rays show?
Yeah, let's do this. Maybe if Giannis gives us permission and we can blind it, perhaps we could share it on social media at the time of the podcast drop. If we get permission and it's blinded, maybe that'd be okay.
Yeah, Giannis will have received an email and likely given permission by that time.
Yeah. So let before we talk about the X-rays, if it's okay, let's break down the physical exam, the key points. So one point that caught my ear was the fact that the PIP joint was stiff in extension. The DIP joint really didn't have much flexion. And when you move the MP joint, it did not affect the PIP joint motion. So kind of three separate points. And so number one, moving the MP joint and reassessing the PIP joint is a test for intrinsic tightness. I assume that's what Giannis was getting at, and though there's no evidence of intrinsic tightness. That's number one. Number two, the PIP joint's stiff. Now, classically, I would say that could be from maybe three reasons. Maybe you have others. Number one, there can be a capsular contracture dorsally. Number two, there could be significant scarring of the extensor mechanism. And number three, there could be something intrinsically going on inside the joint. Any other reasons you can
So,
think of? Yeah,
well, no, I think this is good. So, first off, for any of you listening who are in training, this was a perfectly presented case in terms of all the pertinent positives and negatives. I mean, honestly, you can tell that this doc knows what he's doing. So, I think the points about the reasons for the stiffness are really important. So you mentioned that there could be a dorsal capsular contracture, and a dorsal contracture would limit you from, passive flexion, presumably, right?
exactly.
And then you mentioned that there could be some adhesions on the extensor mechanism, which would limit you, it could potentially limit you in both potential for passive flexion as well as the ability to actively extend. So that, and then I think you have made, you had a great presentation and paper with Marty Boyer that we often reference here in our teachings about the stiff finger. It was a great ICL paper. And you can't even assess active motion until you have passive motion. And I think that's a super important point. And then the last thing you commented, you actually had three things this time, not two. I'm impressed. You've grown. Your third thing was about potential intrinsic issues in the joint. So what do you think that could potentially be in a case like this, where you have a PIP fracture dislocation? And just to give away a little bit of the X-ray, there is a very small volar plate-ish type fragment, not a huge piece that we would get super excited about putting a screw in or anything like that, but one that would, give us pause.
Yeah, not a piece that one would think needs to be fixed, but in addition to that, the joint alignment was not ideal, and we can
Right.
talk about more. I would say that an intra-articular malunion could limit flexion, and obviously joint subluxation can limit flexion. So
Now,
either of those.
are you
Uh,
focusing on the limitations in flexion because that is just the first way to talk about it, and then we'll talk about the limitations in extension later, or because that's just what Giannis said is bothering this patient?
Well, both. I think we're starting by, thinking about the reasoning behind the limited flexion. Is it only the joint? Are there secondary considerations as well? I think in this patient who, again, the x-rays do show some joint subluxation in the coronal plane and also some slight dorsal subluxation in the sagittal plane with some mild arthrosis. So all of those things can be hurting us, but doesn't mean they're the only reasons for the joint being stuck in extension.
Sure, I think those are great points. So I'll break down the X-rays. So we have what, just based on the image, the file names on the images, it looks like we have one injury image, which is a lateral of the small finger, with it in what appears to be a very long alumifoam splint that wraps around all the way from the tip of the finger to presumably the MPs, based on the appearance on this kind of snapshot of the X-ray. And we've got a PIP joint with a small volar fragment. I'd say probably less than 10% of the surface, kind of more in the volar plate fragment category as opposed to an actual volar lip piece. I think it's probably fair to say. And you've got some subtle dorsal subluxation with, I think, what looks like a V sign on the dorsal aspect of the joint there, suggesting that, as you said, this is not just a volar plate fragment without any instability. There is an element of dorsal subluxation and PIP instability.
Now, the DIP joint is interesting because classically one loses flexion of the DIP joint when the PIP joint is stuck in flexion. So a boutonniere type posture. And the reasoning behind that is, so if you have your PIP joint stuck in flexion, whether it's a volar plate contracture or whatever, what happens there is what should be your dorsal lateral band slide volarly, and then you lose the ability to flex the DIP joint. But this is not that situation. That's the common situation. Here, it seems to me like there's probably just some scarring of the extensor mechanism. And if you believe in the oblique retinacular ligament, then maybe it's limiting us as well.
Right, right. So, I mean, I think that, you've covered a lot of ground there. You kind of switched up and talked about volar. I'm going to try to digest this for everybody. You switched up and talked about reasons for limited extension after we said we weren't going to talk about that with your volar plate contracture. But then to go through the final X-rays that Giannis was kind enough to send us, you've now got a joint that looks like it's chronically subluxated. That looks like it's got some cartilage wear on the base of the middle phalanx. And Marty Boyer would kill me for saying looks like a few times in the last couple of minutes when I described x-rays, but there's cartilage wear at the base of the middle phalanx. So a chronically subluxated joint with some early arthritis. And then as we described above, kind of the limitations in motion, both for the PIP and DIP.
Right. So we did throw a lot at the listeners who don't have who hopefully will have the ability to see the x-rays. But I think fundamentally what we're talking about this case is a chronically subluxated joint. And the real question becomes, can this joint be salvaged? And, for me, and I'd love to hear your thoughts, advanced imaging doesn't help me. So I don't think a CT scan or an MRI gives me useful information. For me, it's about the x-rays and likely about intraoperative decision making, although I always like to go into a case with a plan. How do you think about it?
I think about it the same way. I mean, I think that if this patient had better passive motion, but had limited active flexion or limited active extension, I think an ultrasound might be pretty useful to look and see if you can spot some adhesions. I think that's challenging in some clinical settings just because you may not have the small enough probe to be able to get it on the finger. That's actually a limitation I have in the clinic that I work in mainly, is that we just don't have the small footprint probe to look at flexor and extensor tendons to look for adhesions. But I think if you've got that available, that might be interesting. But truly advanced imaging, such as a CT or an MRI, does not add anything for me.
So in this case, where there looks like, thank you, where there appears to be some arthrosis and a joint that's not particularly well aligned, in a youngish, I don't mean to offend you, this patient's not super young, but is not old either, 45. Do you think it, is reasonable to consider an option to explore and potentially reduce the joint? Or is it your sense that in this case, the horse has left the barn?
I don't think the horse has left the barn. I think this does get down to, and I hate to use this term because it's kind of a catch-all term, but patient preferences and expectations. And if you get the sense that this patient, even if you don't have specialized therapy, is going to be able to do whatever you ask him to do, and understands that at the end of the day, they may still have either the same finger or a worse finger that's been operated upon 1, 2, or 3 times, and is okay with that, and is willing to invest the time, energy, effort, resources to do it, then I think it's reasonable. I would not throw the towel in on this one, meaning give up on this one.
So I think that's very fair. The little finger, we do have some, younger listeners. The little finger is designed for flexion, and it is necessary for power grip. And we get our grip strength from the ring and little fingers. And if that little finger doesn't flex, then functionally it's a problem. And so if we would hope to restore motion to maximize this gentleman's function. And so in this age group, I probably would explore as well, trying to get a sense of whether the joint arthritis is diffuse, or perhaps if we're lucky, it's just the volar aspect of the middle phalanx. And if we can reduce the joint, and if we have to consider something like a hemihamate, we could do that.
Does quantifying the amount of post-traumatic arthrosis on the middle phalanx affect your willingness to engage in some kind of joint preserving procedure? Either quantifying that during intraoperative inspection or during preoperative imaging, even though both of us said that we probably wouldn't. Does that influence? Is it 30% of the joint? Is it 50% of the joint? Does that tell you, like, is this worth saving or not?
I think it does. And let's just use the hemihamate arthroplasty as an example. And I have done a fair number of those procedures, and they're not all universally successful. And I think the ones that are successful are the ones that have a limited amount of arthrosis on the volar aspect of the middle phalanx, and the head of the proximal phalanx is good. And so in those patients, you can really recreate that volar buttress of the middle phalanx. But if the head of the proximal phalanx is arthritic, then my expectations for a good outcome are decreased. And so either preoperatively or intraoperatively, I really do think you have to be honest with yourself. And I think you should have variable options available. So you should potentially be prepared to do a hemihamate arthroplasty. depending on the patient preference. This gentleman's young, but you should be prepared to consider an arthroplasty. That is either a silicone or some type of arthroplasty. And then finally, in a 45-year-old, especially if they, power, grip, and durability is your option, you have to be prepared to perform a fusion because that's probably his best option.
There's a lot to unpack there. I think that's you've said a lot of really important things. You mentioned, a limited, say proximal phalanx head is clean, and you've got some post-traumatic arthritic changes at the base of the middle phalanx. You said a limited amount. What is that kind of threshold in which you're like, oh yeah, this is going to do well, versus you get a little more concerned?
I think meaning, so if we're talking how much arthritis, we're not, the depth of the arthritis doesn't matter. It's simply how much from volar to dorsal of that
Right.
base of the middle phalanx. And what you're trying to do with that piece of bone is, recreate a volar buttress. And so, you can replace 70 or 80% of the base of the middle phalanx, but that probably is not ideal. I think if it's 60% or less, I think you're set up to have an outstanding outcome.
And my threshold for that, even though I don't have the same depth of experience you do, would probably have been around 30 or 40%. I just don't, I mean, that's a lot of carpentry that you got to get perfect if you're going for 60 or 70%. But I agree with what you said about wanting all the options. And just to backpedal a little bit for those of listeners that may be a little bit earlier on in the experience, the reason that this base of the middle phalanx is so important is that, as Chuck mentioned, it's a buttress that stops that keeps the joint reduced. And if you lose that buttress, say you have, a big volar lip fragment, that joint is just going to ride out dorsally. And that's what's happened in this case. So you mentioned potentially being ready to do all of the things. Is this a single stage reconstruction for you if you're exploring? I mean, I think some would argue maybe, do your inspection, do your releases, get all your passive motion, ensure that you can keep your passive motion and then come back. But I can also see somebody saying, why would you go back to a joint twice?
Look, I mean, a single stage operation is always preferable, but if the patient is insistent and you believe that there is a reasonable chance of success, then absolutely you can always come back and do a fusion or do a different type of arthroplasty. And in a young patient, this joint has some coronal instability, which is not the kiss of death, but you would prefer only sagittal instability, that is the middle phalanx riding dorsally. That would be the preference for a hemihamate arthroplasty. When there's coronal instability, it can still work, but it's just a little trickier. But I think in this patient, I would approach it volarly with the idea that I'm going to work to save the joint.
So this is a plan for potential single stage volar approach, shotgun open the joint and take a look at what you got. And then potentially if the defect is defined enough and you think you can do your carpentry, going to the hook of the hamate. Is that a summary of your plan?
Yeah, just you misspoke, and I'll just edit out, not the hook of the hamate, going to the
Oh, sorry, yeah,
dorsal hamate. Yep.
right. So just to summarize your plan here. So if this is somebody who, we believe could do well with a single stage procedure, volar approach, shotgun open the joint, take a look at the base of the middle phalanx, and then plan for a hemihamate arthroplasty.
If we're going forward, and I think there's some element of examining in the clinic, also live serum fluoroscopy can be helpful. This is not a slam dunk by any stretch. If this patient said, look, I need to have one surgery, I need to know it's going to work, and I don't want to take any chances, then the absolute right answer would be a fusion, 100%. And if I fuse this joint, I'd fuse it in about 50 degrees of flexion. And I think the patient would do really well. But if I could restore motion in a painless fashion, then we'd all be happier.
So to summarize for fusion, is that tension band? Is that a little plate?
I'm a tension band fan. I do that from dorsally, which is a little complicated here if we're going to go volarly first. But what about you? What's your first choice?
If we were going to do a fusion, I tend to like plates, compression plating. I think that we talked about this on a prior episode. I actually mentioned it recently with one of the fellows. We were doing an MP fusion for a thumb. And, their experience recently with one of our partners, Marty Boyer, was, they did a bunch of tension bands on somebody's PIP joints. And I just like the dorsal plating. I think it is somewhat lower profile, and if you actually put the screws in and so that they're not sitting out, I think it probably is a little less prominent than some tension bands when they're not done perfectly well by somebody like with the experience like you. Costs more, obviously. You don't always have to use the locking screws or the fancy technology, but I think some of these plates that are in the existing hand modular sets are pretty nice.
Yeah, especially the new plates that are designed for it. There's no doubt they make it a little bit easier and they decrease the fiddling. But yeah, I think this is an interesting case. It's the PIP joint, as we all know, is super tricky. It has to be anatomically reduced, and so the missed opportunity, not necessarily by the surgeon who wrote in, but the missed opportunity was identifying a non-anatomical reduction early and correcting that. Because if you don't get the joint perfect, even if it requires a K-wire, if you don't get the joint perfect, it's going to go in the wrong direction. So you have to have an anatomical reduction. You can always deal with stiffness, but you have to have the anatomical reduction first.
Right, yeah, and there are a lot of ways to get to that anatomical reduction, from the earlier identification of the subluxated joint. Even something as simple as a dorsal blocking splint, checked under fluoroscopy and, kind of looking and seeing the position of stability of the joint and acknowledging that you're going to have to flex the PIJ to get it to be concentrically stable, and that you're going to have to fight through some of that lack of extension later on, but you are going to get the flexion that you are wanting. And if you don't do a dorsal blocking splint, there's a dorsal blocking pin. Then you kind of progress up the ladder to something like a dynamic X fix, a Suzuki type frame. And then you kind of get into these really big reconstructive options if you have something that remains unstable. Do you ever just pin the joint in flexion? Not a
Uh,
dorsal blocking pin, but just a pin.
I have. I mean, it's not my first choice, but again, you got to figure out a way to get the joint stable, let the soft tissues heal, take out your pen, then worry about motion later. So yeah, so in the right situation, which would be a really complex situation, I don't think it's wrong to pin the joint. I really don't.
Right. And then I do want to touch on one thing that you mentioned. You mentioned this would be a volar approach and, shotgunning the joint. How do you deal with the dorsal tissues, the dorsal capsule potentially being tight, which could limit your flexion, both the capsule and potentially the extensor tendons?
Yeah, so and that is Marty and I think all of us now have this sort of the same belief that we don't like operating on both sides of a finger at the same time. And the theory there is that if you operate dorsally and volarly, then it's probably too much, especially for a little finger, and you'll get resultant swelling, and the swelling will limit your therapy success after surgery. And so we typically operate on one side only. In this situation, if you're going volar, I think you can deal with the dorsal capsule without too much trouble with a freer elevator or something like that. I think it's a little trickier to scooch around, so to speak, the side of the joint to get the extensor mechanism. So I think that's a fair concern, but that may mean you're looking at two surgeries.
Right. And I think the extensor tenolysis, if you do have to do it, is a nice one done awake. So kind of lower less morbidity for the patient, and honestly, you get some useful information. And you're lucky if you get to that point where you're working um, on the extensor mechanism after such a big surgery. So just to summarize for Mr. Yanis, who was kind enough to send us this case, the consensus between Chuck and I would be for probably a single stage surgery, really going for your release and moving towards a hemi-hamate if at all possible. So single stage, go big or go home.
Yeah, looking for the home run with the baseball analogy, given the All-Star games tonight. Looking for the home run, but it may not be possible. And if it's not possible, then you should do the best thing for the patient, which is probably providing stability with the PIP joint fusion.
All right. So I wanted to zoom through a couple of other quick emails. We have an email from a longtime listener who recently enjoyed our episode about FPL rupture. And I'm not sure if I have permission to share his name, so I won't. Maybe we'll reveal it in a future episode. But a hand surgeon in the U.S. Who uh, asked us about potentially what's the role of IP joint fusion for somebody with a really chronically, delayed FPL rupture after, the case that this listener is mentioning is 13 years after volar plating had an FPL rupture. So what do you think about thumb IP joint fusion as a treatment option? The patient he's describing is actually, I think both of us would agree, is elderly, 85 years old.
Yes, a little older than I. There's absolutely nothing wrong with an IP joint fusion. And I think it's a conversation with the patient and hopefully the family, because you're not giving them back what they had before. And that's problematic for some patients. I think you would provide a really good thumb for that patient, and they can use the thenar musculature for flexion of the MP joint. And I think the patient would do really well, but they would not be happy unless they truly understand what you're accomplishing with that IP joint fusion. For that reason, I tend to prefer to reconstruct the FPL, but it's not wrong to fuse the IP joint.
Yeah, and I think this listener had a really good point that he tried non-operative treatment to see if just trialing it to see if the patient could live with it, but the patient didn't like the instability. And when somebody doesn't like instability, I love the option of giving them maximum stability with the fusion.
Yeah, it's a great point. It's really a great point.
Would you go ahead and remove the volar plate? If the FPL is already gone, do you just remove the plate at the same time? Because how often do you see FDP issues for the index through small?
It really depends on how prominent the plate is. Sometimes you're surprised with an FPL issue, and sometimes you're not surprised if an FPL issue develops. If the plate is not prominent at all, I wouldn't feel the need to remove it. If there's any question though, and you're going to the operating room, take the plate out. That's my opinion. Do you see it any differently?
I don't. I think I have a lower threshold to remove the plate. But this listener actually did something pretty slick and did the IP fusion awake. So if your point is if you're going to the OR, but if you don't have them under anesthesia, you could clearly do a volar plate removal awake. It's obviously a little more tedious and trying, and a little more effort on the surgeon's part. But if the patient is undergoing any sort of anesthesia with a block, at least, a regional block and some sedation, I think it's fair to just take the plate out, and both of you don't have to worry about it anymore.
Yeah, we had a really interesting discussion in our Monday morning conference about a classic rheumatoid patient, which got me thinking, and Marty and I have been talking since. There are things that we are losing that trainees just don't get to experience, and the care of the rheumatoid hand is one of those. And I've had a couple this year, and we saw that one, but they just don't happen much thanks for the disease-modifying anti-rheumatic drugs. Tendon transfers are not exactly well, they're just not as common as they used to be for a lot of reasons, including what you have personally single-handedly destroyed in our patient population by using nerve transfers. Without you, we'd be doing way more tendon transfers.
Oh, hardly, hardly. We did write an interesting paper. One of our current partners, Marie Morris, when she was a resident, we got a nice grant from the Hand Society to pull data from the ABOS, looking at how frequently nerve transfers were being used in new graduates who were doing their case logging. It went up 6 times just over the course of a decade. Now, probably a lot of that is, to be honest with you, kind of the AIN, ulnar nerve supercharging kind of thing. I don't think there are tons of new board eligible orthopedic surgeons that are doing overlands and all sorts of transfers. But the very accessible transfer like an AIN pronator quadratus supercharge is probably being done a lot. I'd say two things in your fashion. One of us brought up in conference how it's a shame that our trainees are not learning more about these tendon transfers. And then another one on this podcast then shut them down immediately with some quip about intergenerational differences. Yet you then went and talked about this with Marty about what to do about it. So you're welcome for the idea. I look forward to seeing whatever content you and Marty create. I agree. It's a shame that our trainees don't get the access to care of the rheumatoid hand and wrist. And then with regards to tendon transfers, completely agree. I actually tried to get the residents and fellows to the tendon transfer cases that we do for nerve patients as much as we can, because you need to know how to do some of these basic things. If you're going to call yourself a comprehensive nerve surgeon, you need to know how to deal with issues when they come to you late, or when your own reconstructions or somebody else's don't work.
Yeah, all well said. Marty and I are not producing any content, but
Oh yeah, no, I think you are.
I've got enough content to produce. What we talked about is, in a practice like ours, there clearly is already subspecialization. And, do we all need to know how to reconstruct the rheumatoid hand? And the answer to that clearly is we do not. But the concepts and the kind of approach is absolutely something we have to still teach. But it's interesting because, I've thought about this a lot. As we get into practice, you do not want to narrow your practice too early. And you and I have talked about that. You want to keep your practice as broad as possible for as long as possible. And then you want to narrow it to stuff you are passionate about, because once you narrow your practice, you can't go back out. But things like this, super specialized things like the rheumatoid hand, or, Marty and I trade back and forth. I do wrist arthroscopies, he does joint arthroplasties. But we're older. So I understand where our younger partners don't want to give up something like the rheumatoid hand. They want to be a part of the reconstruction. So I think we have the best of both worlds. He's not sending the patient to Marty, he's doing the case with Marty.
Yeah, agree entirely. And honestly, I've been on both sides of that in terms of sending the case versus doing it, because sometimes it is really hard to just coordinate schedules and not delay the patient's care for many months just so you can have that experience. So I'm torn on that, and I feel like that's something where I wish I had more experience with the rheumatoid hand and wrist with arthroplasties. Fortunate enough to have a partner who excels at it. So yeah, I think that's and it's certainly a different ballgame once you step outside of the academic arena and you're in a smaller group, and or potentially solo practice. I
Yeah.
wanted to squeeze in one more listener email as it relates to FPL. So Bob Vandermark, who has listened for a long time and has always given us permission to share his thoughts. He shared that about the FPL rupture, his junior partner couldn't find any literature about FPL reconstruction techniques. So, when we get our article out there, Bob mentioned that we might want to mention wide awake as an option. He's done one one reconstruction using FDS. And he said the rupture was old and the FPL muscle was not good. And he's kind enough to send us an article about, just general principles about using wide awake to help judge your tendon transfers. So it's a great way to set your tendon tension. And then the other advantage that Bob states about wide awake is that the patient can see what the reconstruction looks like. He said, my patient was a farmer and remarked that the repair looked pretty weak and he would have to be careful not to screw it up. A great example of patient education. So what do you think about that?
Well, I think it actually feeds into what we just said. So if you can do this procedure wide awake, it does negate to some degree an experience issue, because you can adjudge your tension with the patient helping you with active motion. Without that, you have to depend on experience and reading to know exactly how to tension each of these tendon transfers. And so the wide awake surgery may be part of the answer to the lack of experience with these cases. I don't know that I'm up for a lot of wide awake big tendon transfers, but I applaud those who are.
I've done some, and I think that it is way more work on your end. Not way more, it's more work. Just because you've got to, for lack of a better term, entertain the patient and engage them and calm them when, sometimes the local needs to be kind of added back and that kind of thing. So it's more effort in what can already be a challenging case, especially if you've got trainees with you who you want to engage and have participate in the case. But I do think, the tensioning that I've established with doing some wide awake tendon transfers, I've been really happy with. So, I kind of go back and forth, and you always kind of wait for the right patient, because, the patient's condition and your planned surgical treatment may be right, but the patient themselves may not be right for Walland.
Exactly. Well said. Well, we kind of went all over the place, even though we only had two cases. I think we approached it from a lot of different angles. I hope it was comprehensible, and hopefully we can share those x-rays.
Yeah, absolutely. So thank you everybody for listening. If you like the grab bag stuff or you have a suggestion for a topic, feel free to email us, handpodcast@gmail.com. And we look forward to talking with you guys again soon.
Yeah, and I think we do have a couple of we've talked about some topics which I am really excited about. One, we may have a guest on to talk about distal radius malunions and approaches in 2023. And two, we need to hit the therapy episode. We have some real opportunity there, because it's been too long.
Macy's back from her parental leave this week.
Oh, good
So
timing. Good
she'll be
timing.
chomping at the bit for sure.
Have a good one.
All right, see ya.